You're listening to the American College of Cardiology's CardiaCast. Today's discussion is the third part of a series of educational activities that include 4 CardiaCasts on the evaluation and management of ATTR CM, or transthyretin amyloidosis cardiomyopathy. This series is brought to you by the American College of Cardiology Foundation and MedIQ and is supported by an educational grant from BridgeBio. Keep an eye out for more engaging discussions on ATTR CM coming soon. And for additional complimentary CME and resources on this topic, visit MedIQ, that's med-iq.com, or acc.org. So, first of all, I'm going to introduce myself. My name is Sarah Cuddy. I work at the Brigham and Women's Hospital and I am director of the Mass General Brigham Amyloidosis Program. And I have the pleasure to be accompanied by my long term friend in amyloidosis, somewhat mentor sounding board, Dr. Prem Soman, who is Professor of Medicine at University of Pittsburgh and Director of the Cardiac Amyloidosis Center at UPMC, and many, many more accolades, but we only have a short amount of time on this podcast, so I'll stop there. So we're going to focus on ATTR cardiomyopathy treatment updates from ACC 2026 and new data related to treatment decisions. So, kind of looking through what came out at ACC, any new publications with late stage clinical trial data, and we're going to discuss how they're affecting our clinical practice. So, Prem, to start off, at ACC, what did you find the most exciting?
Hi, Sarah. Nice to see you and lovely to be here with you. And it's a great time to be discussing TTR amyloidosis. And, as I was preparing to get on this call, and thinking about this, I just wanted to recapitulate that, even 10 years ago, we thought this was a rare disease. It needed a biopsy for its diagnosis, and we had no therapies. And in just a few years, all of those conditions have changed. And we now know that wild-type ATTR is not a rare cardiomyopathy. We don't need a biopsy to diagnose it in most of our patients. And we've got not one but many therapies. So that is a remarkable transition for any field. And so it's a really exciting time. And ACC had a number of presentations on therapy of TTR amyloidosis. I guess I will start with the OLE presentation of acoramidis data, the ATTRibute CM trial, which I had the privilege of presenting. And I think this was the only sort of randomized OLE data that came out in ACC. Now, acoramidis, as you know, is a potent stabilizer of TTR. We have 2 classes of therapies for TTR. We have the stabilizers and the silencers. And this is one of the stabilizers, and its efficacy was originally established in the ATTRibute CM trial, which randomized patients in a 2:1 ratio to both acoramidis and placebo and showed a significant reduction in all-cause mortality, cardiovascular hospitalizations, analyzed in multiple ways, including the Finkelstein-Schoenfeld pairwise comparison and also the traditional methods of Cox proportional hazard reductions. Now, what I presented was the 54-month readout of the open-label extension phase of the ATTRibute data. And what it showed was that at 54 months, there was still a very significant reduction in the hazard of all-cause mortality, cardiovascular mortality, and cardiovascular hospitalizations. So very strong evidence of a durable and sustained benefit of acoramidis in ATTR cardiomyopathy.
Yeah, really exciting data on the durability of these therapies for our patients. And I kind of had the privilege as well of looking at a sub-analysis of that OLE study, looking at TTR levels and also the KCCQ cardiomyopathy, which I presented as an abstract at the ACC. What we can see is a real stability in the KCCQ score of those patients who initiated therapy in the randomized control double-blind period and were extended through the OLE period. We see very little change in the KCCQ in that population. And then happily, we do see those patients who transition from placebo to therapy in the open label extension. Again, we see their KCCQ stabilize in that period and also a marked increase in their TTR levels. I actually also had the privilege of looking at a few post hoc analyses of the Helios B study, and one that I had presented on was looking at diastolic dysfunction in this subgroup. So, the Helios B study was the study of the other class of medications, which are the gene silencers, which knock down TTR production at the level of the liver. So there's been a number of echo analyses done of this, but looking specifically at grade of diastolic dysfunction had not yet been done in this trial, which was 1-to-1 randomization to receive vutrisiran or placebo over a double-blind period of up to 36 months. So we looked at the different diastolic grades at baseline and divided it into diastolic 1 and 2 versus diastolic grade 3, thinking of grade 3 as a much more advanced phenotype. And that's what we saw. Those with grade 3 diastolic dysfunction at baseline had worse outcomes. But happily, those patients who were treated in the treatment group had a clear benefit of treatment. So even in this kind of more advanced echo phenotype, we see a benefit for these therapies. So for me, that was pretty kind of nice, exciting data. I don't know if you saw anything else at ACC that you found compelling, Prem.
Well, along the same lines, Sarah, one group of patients that we all find challenging clinically is the patients with already established advanced disease. People with very high NT-proBNP levels or class 3 or class 4 heart failure. We often wonder whether treatment is even beneficial, and we're talking about very expensive therapies. So there was a subgroup analysis of Helios B that Ron Vitellis presented, showing that the silencer therapy, vutrisiran, actually reduced the proportion of patients who advanced to this advanced stage of disease, and also the drug was beneficial in this group of patients. Now, this is a small subgroup analysis, but I think that's encouraging data in a particularly challenging subgroup of patients that we all encounter.
Yeah, for sure. So, kind of thinking of what you've said and what we've talked about, now we have all this data about the effectiveness of these therapies across the board. They've shown to reduce heart failure hospitalizations and mortality. So, how are you now approaching the management of ATTR in a new patient?
Yeah, this is the million-dollar question.
Yeah.
As you know very well, cross-trial comparisons are fraught with challenges and the potential for misleading data, because every study recruited a different type of patient. And so, given the lack of head-to-head comparisons, I don't think we have any firm data to go by in terms of, choosing therapy for a patient who presents for the initial therapy of ATTR cardiomyopathy. In my practice, I sort of involve the patient very much in this decision. Some people have a choice between injectables and oral therapy. Some patients have a choice between single-day therapy and twice-a-day therapy. And there are occasional drug interactions that mandate the choice of another therapy. So it's based on these extraneous factors rather than in any particular characteristics of the drug itself at this point.
Yeah, I couldn't agree more. I used to joke that my new patient appointments, it used to be pretty straightforward. Well, before 2019, we had no therapies, so it was kind of a tough conversation. But then for many years, we only had one therapy and that was it.
Yeah.
And now definitely I've had to add on extra time to kind of go through the merits and kind of pitfalls of each therapy approach for patients to help them make that informed decision. So, like you said at the very start, this has been a hugely exciting decade in cardiac amyloidosis. And kind of outside what we've seen at the ACC, was there anything else that's been presented this year that has kind of excited you, caused you consideration, or stuff that you're really looking forward to? That's a big question.
Well, I would sort of say that there are two sort of sets of data, I think, that has caught everybody's attention. One is a series of data relating to structural and functional change with therapy, and we saw the echo data from Helios, the CMR data from Helios, and from ATTRibute CM. And this is a very interesting and intriguing sort of area. While imaging, and we're both imagers, while imaging has been so transformative for the field, right? I mean, scintigraphy has now shown us that there's so much more amyloid than we ever thought. And two, it has actually made it so much easier to recruit patients into trials. Imagine if for each of these trials we had to have a biopsy in every participant. But despite the transformative effect of imaging, it is interesting that, the clinical trials, we don't have imaging endpoints for clinical trials. I mean, we don't even have imaging endpoints for monitoring, right? And so we're all looking very carefully at this data. And I think, the data that have been presented are a step forward, but I think we are a ways away from using imaging as surrogate endpoints in large clinical trials. I mean, these are all small changes in measured parameters like global longitudinal strain or ECV. They're all measured in expert labs by highly expert operators. And interestingly, these small changes are compared against an untreated group, right? So small changes, you can attribute significance to them by comparison to a placebo group or an untreated group. If you have a small change in an individual patient in the clinic, that's much harder to interpret than in the context of a clinical trial. But I think the data are accruing, and that's a very interesting field. The other very interesting aspect in all of this is our knowledge about TTR levels and their significance in the stabilizer arena. There's a lot of new data coming out, and that again is very interesting.
Yeah, I think there's been nice data to show prognostically when patients increase their TTR levels on stabilizer therapy, we can see that this can correlate with results like improved survival, which is quite compelling, especially when it's a pretty simple biomarker to check in the lab. But I agree with you, the imaging kind of side of this is so compelling. And I think this is kind of fortuitous that we're recording it today because there was just top line results released from the evusematide study, which is a novel pan-amyloid radio tracer. So this was a phase 3 study looking at the diagnosis of cardiac amyloidosis using this novel radio tracer, and just very provisional top line that it met its primary endpoint. We don't have any more data, or at least that we can disclose in a public forum. But I think this will be hotly anticipated for me, kind of looking at exactly what that study found. And will this be a novel radio tracer that potentially is more sensitive than the bone avid radio tracers we're using at the moment for cardiac scintigraphy, and also help us across the other forms of amyloidosis? And I think for me also, the kind of hotly anticipated trial of this year will be the CardioTransform study of another gene silencer, so another injectable medication, and that's eplontersen. We anticipate that we should have the results of that at the end of the summer.
Yeah, I think CardioTransform would be a very exciting one because it will be the largest cohort of patients trialed in a randomized fashion, which also gives us the ability to interpret the subgroup data with a little more confidence because those numbers are going to be bigger. And I think, yes, you took the words out of my mouth, evusematide, very exciting. We have to figure out where it fits in the armamentarium of our imaging tools, but it's a very exciting step forward.
Yeah, and that brings me to my last question. What do you think are the key unanswered questions that remain across these trials?
Well, I could talk to you for the next 2 hours about that. It always amazes me, despite so much development and transformative change in this field, there's so much that we don't understand about this disease, beginning from basic pathobiology and what happens in the myocardium when you treat a patient with amyloid. Is it a reduction in the fibril burden? Is it a reduction in the toxic component? And all of these play into the uncertainties around monitoring and imaging, right? If you don't know what happens, you don't know what to image. And so I think, those are the areas that we're all looking at with great anticipation for more data to educate us on what happens, and how we monitor disease is another very, very important aspect that there's still a lot of questions in that area. We saw the consensus recommendation for looking at the various, functional parameters and the laboratory parameters that is recommended to be used for monitoring patients, it still is very challenging. Most of us, I think you would agree, rely on clinical parameters of heart failure severity and progression and outpatient diuretic therapy intensification and so on and so forth. So to get some more concrete understanding around these aspects would be very useful.
Yeah, I couldn't agree more. Like when you can tell a patient, okay, things are progressing or things are stable with kind of absolute certainty or more certainty that we have at the moment. And then also, we're in a data free zone where it comes to switching between any of these therapies, or very limited post hoc data exists. So I think it would be great if that can be collected. Unlikely to be in a randomized control trial fashion. It'll probably be on us to collect it from our own clinical practice and kind of present it in kind of registry or retrospective cohorts. But that kind of data would be helpful.
Absolutely.
So I think we could keep going and going, but I don't know how long people would listen to us for. Um, but it's been a lot of fun, and I want to congratulate you on that presentation at ACC on the OLE data from the Attribute study of those results out to month 54. I think it was just very compelling data for us identifying this disease early, getting patients on therapy as soon as we can when we identify them to have ATTR cardiomyopathy, to see these excellent outcomes up to 54 months. So, with that, I am going to thank you very much for your time today, Prem. And thank you very much again to ACC and MedIQ for giving us this platform to have a nice chat with each other. And like we said at the top, please check out the websites for further information.
Thank you, Sarah. Always such a pleasure to catch up with you.